Good afternoon, everybody, and a very warm and hearty welcome to our discussion today on the subject of dengue diagnosis, advances and challenges. We're very pleased to have with us today Dr. Reena Sachan, Head of Department of Microbiology at the Motilal Nehru Medical College in Prayagraj. Dr. Sachan, thank you very much for taking the time out and your valuable time out and spending it with us from educational and academic purpose. Because dengue today has dominated. We're at the start of the monsoon season, and dengue is one of the leading causes of illness in this vector-borne season. So India contributes almost 1/3 of the global workload in terms of dengue diagnosis and dengue cases. So without further ado, I'll hand over the forum to Dr. Reena Sachan. Dr. Sachan, the floor is yours, ma'am.
Thank you so much. Thank you, Team J Mitra, for giving me opportunity to speak on the valuable topic. I would just so good afternoon, everyone. Today I have been given the topic to speak on about dengue, an overview, diagnosis, advances, and what are the challenges that we are facing right now. Screen is not actually moving.
Next, ma'am. Next. Only next.
No. It's
click on and
I'm just clicking. It's not coming. Shall I start? Stop share again. Then again restart.
you can, ma'am. No problem.
Is the screen visible now?
Yes, visible, ma'am. And just put yes, click on slideshow.
Slideshow. Yes. Now it's coming. So sorry for interruption. So as moving on to the topic, first of all, we need to know that what is dengue. As in African language, it is said that dengue means sudden cramps due to an evil spirit. And this is very true because it has been called as breakbone fever as well. This is one of the most important prevalent mosquito-borne viral disease, and it is a basic health problem in tropical and subtropical region. As already told, that 1/3 of the Indian subpopulation is also involved in this disease. Up to 100 million cases have been reported to increase in dengue virus infections worldwide, as per WHO. And this disease is transmitted by the bite of Aedes aegypti mosquito. The patient usually presents with the flu-like symptoms that may be asymptomatic or may be symptomatic, but in few cases may be so severe that it may be fatal. And it has been seen that almost all of the part of India is involved, but except Ladakh, most of the union territories and states have been involved, and we have seen reporting of dengue cases in India as well. Coming to historical perspective, first clinical description was given by Benjamin long back in 1780. And in 1906, Bancroft associated the stillbirths and abortions with the dengue epidemic. He also proved that it is transmitted by filterable viruses. Whereas in 1919, Cleland and co-workers showed that there is a vector responsible for the transmission of disease, that is female Aedes aegypti mosquito. Hammond et al. Reported that he isolated dengue viruses from ill patients in Philippines and Bangkok, and he also studied about the severe stages of dengue, that is a dengue hemorrhagic fever and dengue shock syndrome. Coming to the virology, it is, as already told, it is a mosquito-borne virus. So it belongs to arboviruses and to the genus Flavivirus. It is a small and medium-sized virus, which is basically single-stranded positive sense RNA having nucleocapsid protein, large envelope glycoprotein, and small non-glycosylated envelope proteins. It consists of small icosahedral nucleocapsid. What we see in the patient is that its replication occurs in the cytoplasm of the infected cell, and maturation and development is seen inside the cells. Basically, a plasma membrane of or other intracytoplasmic membranes, like mostly endoplasmic reticular membrane is involved for its budding. There are 4 basic serotypes that have been observed in dengue. These are DEN1, DEN2, DEN3, DEN4. But in 2013, Bangkok has also reported another serotype, that is DEN5, but it has not been reported yet in India. The peculiar thing about these serotypes is that these are antigenically related and cause diseases rising from the spectrum of dengue fever to dengue hemorrhagic fever, and as well as dengue shock syndrome. Epidemiologically, it involves over 100 countries, and an estimated burden that we see is that about more than 390 million infections are seen annually, and about 96 million cases are showing the clinical symptoms. And these symptoms are basically seen and have association with the rainfall and the temperature. Near about 30 to 35 degree of temperature that is seen during the rainy season is most of the important cause. And where another important cause lies is the mosquito breeding sites. During rainy season, there are many mosquito breeding sites. So this gives rise to the abundance of this infection transmission in the patients. Age distribution tells that it is almost seen in endemic countries, like young children are most commonly involved. And the population in endemic countries, older population is seen to be less infected because of the immune response present in them. There is no male and female sex differences. Man-to-man mosquito cycle, man-mosquito cycle is usually seen. And in country like India, monkeys are also responsible for transmission, as in between they also lie in the cycle. What we see that mode of dissemination in the patient after biting of the mosquito is basically hematogenous, and it may also transmit via lymphatics. And the basic site that is, it shows the virus shows tropism for reticuloendothelial system. So basically involves bone marrow, spleen, lymph node, liver, and even other organ systems are also not spared. They can involve lungs, heart as well. This is the slide which shows the distribution of dengue in India. It shows that almost more than half of the India is covered. And according to National Vector-Borne Disease Control Program data, last year's data that have been total 94,198 cases have been reported to be dengue positive, and among them 90 deaths were seen. So one important thing is that we should have the knowledge about the communicability of this disease. Basically, female Aedes aegypti mosquito, it is, as already told, that it is a tiger mosquito. It has black and white stripes, and this is basically a day biter. It bites and mainly feeds on human beings in domestic and peri-domestic situations. It takes blood meal from person during the acute febrile illness, and from the patient, then it again bites to the another healthy person, and thus it transmits the disease. The extrinsic incubation period that is seen in mosquito is about 8 to 10 days, and mosquito then becomes infected. And after biting to the healthy person, the intrinsic incubation period of 4 to 7 days is there. That may range as short as 3 days to as long as 14 days in the healthy patient, a healthy person, and thus the patient starts developing the symptoms of dengue. One thing more to emphasize here is that the vertical transmission in infected female mosquito is also seen. Clinically, what we need to know about dengue is that some of the person may be asymptomatic and some may be symptomatic. So the spectrum of symptomatology varies. That ranges from asymptomatic stage to very severe stage, like having mild fever to the severe bleeding, shock, and organ dysfunction. And dengue infection usually involves 3 clinical phases. Febrile phase, critical phase. So clinical dengue fever includes basically more of the following manifestations. That includes headache, retroorbital pain, myalgia, arthalgia, rash, hemorrhagic manifestations, thrombocytopenia or leukopenia, or certain warning signs and symptoms. How we can define the case? That is, it may be a probable dengue fever, or it may be a confirmed dengue fever. When we call it as a probable dengue fever, a case that is compatible with clinical description of dengue fever during an outbreak, we can consider it as a probable dengue fever, or a non-ELISA based NS1 antigen test has been done, or non-ELISA based IgM positive cases are like those done by rapid diagnostic kits can be considered as probable dengue fever, because a positive test by a rapid diagnostic test will be considered as probable due to poor sensitivity and specificity of the currently available rapid diagnostic kits. And when we can say that this is a confirmed dengue fever, a case compatible with the clinical description of dengue fever with at least one of the following. And this include that whether the dengue virus has been isolated from dengue virus culture techniques, like from serum, plasma, or leukocytes of the patient, or it may be maybe the demonstration of IgM antibody that may be demonstrated by ELISA, and that gives the positive result in patient serum sample, or the demonstration of dengue virus antigen in serum samples by NS1 ELISA test, or there is IgG seroconversion in paired sera, which can be taken 10 days apart or after 2 weeks apart, and that too it should show fourfold increase in IgG titer. As already told, there are 3 phases of dengue fever. The first one that includes febrile phase. It is patient presents with high grade fever, and that may be biphasic. This febrile phase lasts for 2 to 7 days, that is associated with headache, flushing, vomiting, myalgia, arthralgia, macular and maculopapular rashes, rubuliform rashes. These rashes can be seen over the face, neck, chest, abdomen, and they may appear after 3rd to 4th day of the fever. But as the fever wanes, then these rashes also starts fading. There can be bleeding manifestations as she's seen in the figure. The petechiae is seen, and subconjunctival hemorrhages is seen in the second picture. There can be facial puffiness, conjunctival congestion, pharyngeal edema, lymphadenopathy, hepatomegaly are other manifestations. Then petechiae can be seen on skin or on the palate. Bruising sites are also seen that can be visualized very well by performing the tourniquet test. See the picture here. The patient is showing in the first picture. Dengue patient is seen with the maculopapular rash. And in the second one, the impression mark on the skin of the dengue patient is seen, that is showing the pale skin mark when blanching has been done. Second phase involves the critical phase, that is also called as leakage phase, and this phase occurs in 5 to 10% of the patients, of all the dengue patients, and this is seen mostly in the secondary dengue infections. It means that secondary dengue infection means that once the patient has been infected with dengue, and next time that patient is again infected, might be from the different other serotypes. And patients secondary in the critical phase is quite common in patients with comorbidities and active co-infections as well. And this phase begins after 3 to 4 days of the fever and will last for about 20 to 48 hours. The critical phase is characterized by vasculopathy, coagulopathy, leading to plasma leakage, and there is excessive hemoconcentration and bleeding. And in this phase, the hematocrit value is seen to be rising. Eventually, that may lead to shock and organ dysfunction, and that may lead to fatal situations. And next phase is the phase of recovery, that is called as convalescent phase. Here, what happens is that extracellular fluid losses owing to the capillary leakage returns back to the circulatory system, and hence we start seeing that signs and symptoms of the patient are improving. And this phase occurs 2 to 3 days after the critical phase and lasts for about 2 to 3 days. Here, the convalescent rashes are seen, and these rashes becomes confluent with sparing areas of normal skin is seen. Patient may present with itching. So lots of pruritus. Patient is complaining of pruritus. Patient with severe shock or organ involvement or comorbidities can take a longer time for the recovery. So the recovery phase can be seen lasting after a long time. And one more thing to keep in mind is that if the fluid replacement is not done carefully and that has not been optimized carefully, the patient may develop pulmonary edema as a result of fluid excess, because again, back to the capillary leakage returns back, and therefore extracellular fluid loss has been reverted back to the body. Now here we can see that in this figure, we see that it has been divided in different phases: febrile, critical, and recovery phase. And being potential clinical issues, what we see that in febrile phase, there is dehydration. In critical phase, there is shock, maybe organ impairment, or maybe bleeding tendencies. Then in recovery phase, there is reabsorption and fluid overload. Being a microbiologist, we are here more concerned with the laboratory changes, and where we can see that hematocrit in the febrile phase starts rising slowly, and by the start of critical phase, hematocrit value has risen, and the platelet count keeps on falling from normal to that can fall up to even less than 10,000, where we need to have platelet transfusion is needed, or if the patient is having any bleeding tendency, then without concerning about the platelet transfusion is required. Then coming to serology and virology, what we see that in febrile phase, viremia is there. Lots of viruses are seen to be produced in the body, and in critical phase there is slightly there is rise after 5 days. There is rise of IgM antibodies, and slowly that progresses after 10 to 14 days into IgG antibodies. So laboratory diagnosis of dengue basically lies on 3 lines, that is virus culture, serological test, and molecular methods. So among the virus culture, different mosquito cell lines, mammalian cell lines are used. These viruses can also be cultivated in mosquitoes like Aedes albopicus. But this virus culture is a sophisticated technique, and it requires a very expert hand, as well as it takes more time. Other tests that we know is the serological tests that are usually we are doing at our center, and these includes both rapid diagnostic tests and enzyme-linked immunosorbent assays. These tests can be a point of care testing like rapid diagnostic test. These tests gives result in very short time of 15 to 20 minutes. And ELISA test that can be done by to identify NS1 antigen, IgM antibodies, and IgG antibodies. These can be done in a few hours. Like it may take 2 to 4 or 5 hours, depending upon the kit. Means kit to kit variability is there. And then molecular methods are there. These are most sensitive and most specific techniques, which includes polymerase chain reaction, real-time RT-PCR, nucleic acid sequence-based amplification assays. So, as already told, that serological markers are one of the important in the day-to-day setting. So, we need to know the serological markers. There are basically 3 serological markers. These are NS1 antigen, IgM antibodies, and IgG antibodies. But the interpretation remains different in primary infection and secondary infection. The person who is getting infection for the first time is primary infection, and when the person gets infection for after another means after first time, maybe due to same serotype or maybe due to different serotype, that will lead to secondary infection. So NS1 antigen is usually produced from day 1 after the onset of fever, and it may last up to 9 days. And after that there is detection of IgG antibodies. For IgM antibodies, these are not produced from the day of fever, but they are produced after 5 days after the fever. So this is very important to know that when the patient presents with fever, then NS1 antigen can be detected, and after 5 days of the symptoms appearing of the symptom, IgM antibodies are detected. These may remain for 1 to 3 weeks, but may persist even for 60 days, and some studies have reported that they may even persist for 90 days. So it takes quite longer time. And IgG antibodies usually appears after 2 weeks after onset of symptoms in the cases of primary infection. In secondary infection, NS1 antigen kinetic shows that NS1 production varies as compared to the primary infection. And kinetics of IgM antibodies production also varies in the cases of secondary infection, because these are produced for a very shorter duration. And that can be seen in this picture, that in secondary infection, IgM antibody titer is very low, and that too, IgG antibodies that we see, it rises very fast as compared to the primary infection that used to give rise to IgG antibodies after 10 to 14 days. Here we see that within 1 or 2 days of starting of the symptoms, IgG antibodies starts to appear. So there are the different tests that these tests show different limitations. So the limitations of these could be that NS1 antigen detection, whether it can be done by rapid CAR test or by ELISA test. The limitation is that of the time, because in early phases, in start of from day 1 to day 5 of the start of symptoms, NS1 antigen can be detected. So it is extremely useful as it, and this NS1 is extremely useful as it circulates in a serum or plasma, and it is a detector of acute infection. Anti-dengue IgM and IgG antibodies via rapid CAR test or via ELISA. These are seen, like IgM is seen after 5th day of infection, already told to you. And IgG is seen in the primary cases, it is seen after 10 to 14 days of infection. And in secondary cases, it can be seen within 1 or 2 days of the infection, of the symptoms. Virus culture techniques, these techniques are, they require especially specialized facility, and they are time consuming. They require 6 to 10 days for cultivation and for the replication of viruses in the culture. And detection of viral RNA via real-time PCR, it is the technique which can detect the viruses in the phase of viremia, that is from and even before the symptoms appear. And but these are very expensive and require specialized facility and technical skills. So there are few salient points about NS1 antigen, because this is important for detecting acute cases. This NS1 antigen is highly conserved glycoprotein. It is produced in both membrane associated and secretory form, that is essential for dengue virus viability. But there is no biological activity that has been established. And this NS1 antigen is detected in early cases from the very first day of the appearance of the symptoms. It is detected both in primary and secondary cases. NS1 antigen is present in high concentration in the sera of dengue infected patients due to during the early clinical phase of the disease. It is highly specific and sensitive. This has to be kept in mind. And it is also useful to differentiate between the different flaviviruses as well. And it helps in early diagnosis of dengue infection when it is very necessary, such as in cases of dengue hemorrhagic fever or dengue shock syndrome. So which is the best diagnostic technique in the current scenario? That question comes to our mind. The answer for this is that detection of dengue NS1 antigen test along with detection of dengue IgM and IgG antibodies appears to be the best method. A few words about the rapid diagnostic kits is that the government of India has ordered these diagnostic kits from 2016, and a positive rapid diagnostic kits of for dengue NS1 antigen and IgM should be considered as probable diagnosis, as previously it has been told, and they must be confirmed by ELISA, because there is a question of accuracy, and because these kits have not been properly validated, and they give the false positive results. So there is a question about sensitivity and specificity, and that too, it also varies from batch to batch. So what we see in small setup laboratories, like every nick and corner in the dengue season, every nick and corner labs are giving the results. These are all by these rapid diagnostic kits, which are based on the principle of immunochromatography. And these small labs usually use rapid test card having NS1 antigen, and sometimes they may be using the combi card that has both IgG and IgM antibodies. So the advantage of this using combi card is that it helps in detecting NS1 antigen along with dengue IgM antibodies in the combined format. But the confirmation has to be done by ELISA. that can be done in IgM capture ELISA, that is also called as MAC ELISA. This as already known that IgM appears after 5 days of fever, and it may disappear after 60 to 90 days. So this is the tool for surveillance of dengue fever as well as dengue hemorrhagic fever. Next that we see here is the procedure that is performed for this MAC ELISA. Upper one part is showing the ELISA titer plate, and what we do is that here we can detect the dengue specific IgM antibodies. Basically, the how it works that this bottom of the solid phase of this well is having and is coated with anti-human IgM bound is bound to the solid phase, and in which dengue antigen is added, and then the serum of the patient is added, and after that the enzyme substrate is added to give it color. So wherever there is slight yellow color, it shows that these are positive for the patient sample. And if the serum has anti-dengue IgM antibody, then it is reported as positive. Coming to turnaround time, it is approximately, it varies from kit to kit, but it is approximately 4 to 5 hours, and cross-reactivity is not seen. That is the advantage. Now coming to the NS1 antigen ELISA-based test that has been introduced by Government of India since 2010. And we see that NS1 antigen is rising in the phase of viremia, that is from the start of symptom to 5 days. The peak is seen, and then slowly it falls down. It is this is highly specific, and it is the one which differentiates between the different group of flaviviruses. And it provides the timely and correct, it helps in providing the timely and correct management of patient, because patient at this time is quite sick. So it is expected that successful application of these assays will contribute significantly to the clinical treatment, etiological investigation, and control of dengue virus infections. Now a word about IgG antibodies detection through ELISA. These IgG antibodies helps to these are produced as already told that these are produced 10 to 14 days in the primary dengue infection cases, and may rise in within 1 or 2 days of the symptoms. So it differentiates between primary and secondary infection. And IgG titers usually rise rapidly in secondary infection, and it may show false positive results, so cross reactivity can be seen. But in the past infection, low levels of IgGs are detectable and has been seen up to more than 60 years. So in terms of symptoms also, IgG levels can be detected, and that is useful indicator for past infection. So this is the picture showing about the primary infection and secondary infection, how the antigen and different antibodies are rising. Now coming to the clinical case of dengue infection, just giving a brief history. A 25-year-old female was admitted with a history of high-grade fever, severe headache for 2 days with platelet count of 90,000. Whose sample was tested firstly for dengue IgM antibodies, and later on the sample was tested for dengue NS1 antigen. And the following observations were seen. The blood sample that was tested for IgM antibodies was initially negative, but when the same sample was tested for NS1 antigen, that was positive. But after 4 days, again the sample was sent of the same patient was sent to the laboratory for dengue NS1 antigen as well as for IgM. So so it was seen that NS1 was negative and IgM was positive. Another scenario is that 80 clinical samples were collected just after the end of monsoon period from the patients with a history of high fever and severe headache, and were tested both for NS1 antigen and dengue IgM antibodies. Only 63 patients were found to be positive. And among these 63 patients, it was seen that they were tested both for NS1 antigen and IgM antibodies, and it was found that only 26%, that is 17 cases, were positive for NS1 antigen, and they were negative for dengue IgM antibodies. 38% were positive for both NS1 antigen and dengue IgM antibodies, and 34% were positive for dengue IgM antibodies only. What we need to recommend, what steps we should follow, what test is to be recommended. According to National Vector-Borne Disease Control Program, ELISA-based NS1 antigen tests are being used for diagnosing the cases from day 1 onward, and IgM capture ELISA, that is MAC ELISA test, should be used for diagnosing the cases from day 5 onward of the symptoms, appearance of the symptom. To maintain the uniformity and the standard of diagnosis, IgM MAC ELISA test kits in our country are being provided by National Institute of Virology, Pune, and that are being sent to SSH labs throughout the country. The last one is the molecular method, where we need to detect the specific genes of viral RNA that can be detected by RT-PCR, NASBA techniques, or real-time RT-PCR. These tests are most specific and most sensitive, and these are detected in blood even a day before the onset of fever to 5th day of illness, that is in the phase of viremia. They can be detected. So we are proceeding towards the end of this talk. That what are the advances that are needed for dengue diagnosis? What we need to have is that we should improve the diagnostic technologies. Point of care tests must be improved, and kits for RT-PCR and ELISA should be having higher specificity and sensitivity. One more word about is that we can introduce multiplex testing, which can simultaneously detect the multiple pathogens. And biomarker discovery is very important because novel biomarker identification can be helpful in early and accurate diagnosis. So what are the challenges in our laboratory that we are facing right now? These challenges are because of the reasons that there is complex nature of virus, and 4 serotypes that are usually prevailing in the society. It is its similarity to other arboviruses as well. So there can be confusion with other arboviruses, and the timing of the sample collection, when we need to collect the sample, and that has to be tested in the laboratory. So coming to them one by one, timing of the sample collection, like in early phase detection, in the first few days, what we need to do, we can go for viral load testing and making RT-PCR as most specific and most sensitive test. Then viral antigen detection can be most effective in the acute phase of viremia. Then serological testing window shows that serological tests are more reliable after the acute phase, and typically from the 5th day of illness onward. And then later, if IgG is to be detected, that can, in primary cases, that can be from 10 to 14 days. Then flavivirus cross-reactivity is seen with antibodies against other flaviviruses like Zika virus, West Nile virus, yellow fever virus, and these tests are responsible for giving false positive results. So this is one of the challenge. Then interpretation of serological test is very important, because that can be a challenging, that primary versus secondary infection, in which IgM and IgG patterns can help differentiate between these. But interpretation can be complex, as in the case of secondary infection, there is no time that we are getting IgM antibodies titer rising, but instead of that, IgG antibody titer rises within 1 or 2 days. And persistence of IgM antibodies seen in dengue cases that may even persist for months. Even for it has been reported that it can persist for 2 or 3 months, which may complicate the interpretation of whether an infection is recent or has occurred months earlier. There is also variability in laboratory capabilities, like in the resource limited setting, there is difficult to perform RT-PCR or virus culture. That can be more definitive in resource where resources are available. Then quality control and standardization of kits is also one of the challenge. Then other challenge is that genetic variability due to 4 distinct serotypes that can undergo genetic mutations and can affect the sensitivity and specificity of diagnostic kits that are available at that particular time, targeting the specific genetic sequences. Co-infections in dengue endemic areas also become one of the hurdle, and these pathogens like malaria, chikungunya, etc. can also complicate the clinical picture and interfere with the dengue diagnosis. Then clinical presentation can also overlap in few of the diseases in tropical countries, like leptospirosis, rickettsial infections may have a similar type of clinical picture, thus making the clinical diagnosis alone modality for proper diagnosis, and that can be only that we cannot go without the laboratory confirmation. Then regulatory and logistic issues are also very important, because supply of reliable diagnostic kits, if it is not there, then that can hamper the timely diagnosis into the of the patient. So take home message is that we all know that dengue is a global threat, basically in tropical and subtropical regions, and there is a significant risk of morbidity and mortality. And due to the complex presentation, we need to also identify the febrile cases of dengue fever, dengue hemorrhagic fever, and dengue shock syndrome. There are challenges that need to be tackled for the timing of sample collection, even for cross reactivity with other flaviviruses, and the challenges can be there in the limited resource settings. Then we need to advance our diagnostic tools so that we can go for point of care testing in acute cases. That would be helping, and then multiplex testing for just making the differential diagnosis, then offering improved sensitivity and specificity to the kits that have been provided. And nothing can be done without the fund. So the global cooperation is very much required, and sustained funding and coordinating with global effort that can be used, and that can be very helpful to reduce the disease burden. So I thank you so much all for patient listening. If there is any query.
Dr. Sachan, thank you so much for your detailed talk on the subject of dengue diagnosis, dengue occurrence, and directions for the future. You know, I must compliment you that I normally have a few questions when I listen to certain subjects, and dengue is one of our, how do you call it, focus areas. But today you have covered everything with such great depth and equanimity that it's extremely difficult for us to come up with a question, to be very honest. You've covered everything from IgG to IgM to future directions, and because that's normally the direction we go in, that if we're because we have a lot of people attending this particular webinar who are focused and who can understand how things need to be shaped up in the future as part of the learning process. But I think you've covered that, especially in your last two slides. You know, that is the crux of the entire presentation. Everybody knows exactly how dengue happens and what, the basics of it, the epidemiology of it. But the future direction is what we look for when we see certain subjects being covered. Because eventually, we at J Mitra, we're looking at doing refining dengue diagnosis. And why we are the only company in the world which has a rapid test, an ELISA test, a fluorescence immunoassay test, and now a chemiluminescence test. We believe that India is a tropical country and dengue is a tropical disease, being that we share 1/3 of the world's burden of dengue cases. So I believe I really could not have any questions for you because you've covered everything in great detail. And I want to also thank you for the fact that going forward, this particular presentation will be on YouTube. So it will serve as a, how do I call it, a Bible or a Bhagavad Gita for people who want to study 30 minutes learning curve on dengue diagnosis. So thank you very much, Dr. Sachan. Pleasure listening to you. And we look forward to another lecture from you soon on a subject choice, ma'am. Thank you so much.
Thank you. Thank you so much. Thank you.
Ladies and gentlemen, thank you for joining us today. We look forward to having you with us on the 28th of June on our next monthly webinar, which will be also on vector-borne diseases as a whole. Thank you, everybody. Have a good day. Jai Hind.